Catheter-associated urinary tract infection is the most common type of healthcare-associated infection. The CDC research has found that prolonged catheter use is the leading risk factor for CAUTI. The use of indwelling urinary catheters has been a long-standing infection control problem, including surgical, medical, and critical care units. The infections related to catheter use impact patients, hospital staff, facility reimbursement, unnecessary use of resources, and facility ratings. Facts associated with CAUTI. The longer a catheter remains in place, the higher a patient's risk is for acquiring a CAUTI. An estimated 560,000 nosocomial UTIs are reported annually. Among UTIs acquired in a hospital, 75% are associated with catheter use. It has been estimated that every year more than 13,000 deaths are associated with UTIs. Hospital surveys have reported that 50% of physicians did not monitor which patients were catheterized, and 75% did not monitor duration and/or discontinuation. The cost for an admission can be increased dramatically for a patient who acquires a secondary infection and has an increased length of stay. Hospitals need to control cost in order to continue providing care in their community. The control or reduction of nosocomial infections is crucial. Costs can be increased into the billions per year nationally. Patient satisfaction is also at stake. CAUTI can prolong recovery and cause pain, discomfort, and even death. Surgical and critically ill patients have a higher percentage rate of catheter use and are at higher risk for secondary infections and complications. Studies have shown that early removal and avoidance of unnecessary catheter use aid in the prevention of CAUTI. Hospitals are implementing patient safety initiatives aimed at reducing or eliminating risks. Programs such as a nurse-driven urinary catheter removal protocol, which is aimed at promoting the discontinuation of catheters as soon as possible, and the bladder bundle program, which is focused on appropriate indications for catheter use and prompt removal, are such initiatives that have shown improvement in the rate of CAUTI for hospitals.
Common themes in the research articles associated with CAUTI were reasons catheters are placed in a patient and the ability to decide if it's safe for the patient or if other alternatives should be evaluated. Another common theme was the importance of collaboration between nurses, physicians, administration, patients, and their families. And some of the common barriers to decreasing the rates of CAUTI were similar in some of the studies. Nurses felt they had competing priorities to keep the patient safe. This kind of fell under the should I remove their catheter and risk they're going to fall because they won't call to go to the bathroom? So they had competing priorities. In the research for nurse-directed removal protocols, the nurses reported a greater sense of engagement when they were allowed more autonomy when it came to their patients and indwelling urinary catheters. This was a common theme amongst articles also, was the sense of autonomy and empowerment, and that the physicians respected their decisions to not place a catheter in some cases. This was definitely a facilitator of better outcomes. Review of 5 qualitative research articles, 3 quantitative articles, and 1 mixed method article. Most of the quantitative research involved the use of a survey to collect data. The qualitative research used interviewing techniques either in person or via telephone interviews. Data was collected and then evaluated for common themes for analysis. Many of the studies interviewed nurses for their knowledge about indwelling urinary catheter use and when it's appropriate and when it's not. One qualitative study interviewed the patient to collect data on their knowledge on Foley catheters. In those studies, the patients reported that if they were not notified or if they didn't know that the catheter was going to be placed, it created anxiety and fear in them. Whereas if the physician had told them after your procedure or at some point during your hospitalization or just before the insertion, they were aware of why the catheter was being inserted, it decreased their fear and anxiety. Some of the study designs for quantitative studies was abstraction of clinical data from the medical record, an online survey, nursing satisfaction survey, a CAUTI surveillance by an infection control nurse. And some of the qualitative study designs were telephone interviews, focus interview groups, and semi-structured patient interviews. Some of the limitations with the qualitative interviews is that with focus groups, you can have somebody trying to take over and their opinion influences the rest of the group. And the mixed method study design was convenient sample focus group and pre and post education test. It was a combined study. Literature review shows that all current facilities that use EBP for CAUTI show a reduction in infection rates. The research also shows there is still room for improvement. The benefits of CAUTI initiatives is improved patient safety along with improved nurse-physician relationship. A takeaway from the literature review is the importance of a plan that will last beyond the study period. Examples of some of the variables found in the research studies were in the quantitative study, the independent variable was CAUTI education for both the nurses and for the patients, and they used surveys to evaluate their knowledge before education and post-education. The dependent variable is the reduction of the CAUTI rates. In the qualitative study, the independent variable was the nurse-driven removal protocols, and dependent variable was reduction of CAUTI rates. And in the mixed method, the independent variable was nursing education once again, and the dependent variable was appropriate placement of indwelling urinary catheters.
Currently, there is no national standard for monitoring patients with catheter infections. We see various hospitals and acute care centers using varying methods according to what they have found or believe produces the best outcomes for their patients. Some frequent standards seen include daily assessment of the patient, including catheter cleaning care and monitoring the patient for complaints of pelvic pain, which can be an indication of an infection. Over the next few slides, we will discuss how Hospital A's standards vary from Hospital B's, and we'll compare and contrast the benefits and faults of each program. Both hospitals are similar in patient size and expertise. Both are teaching hospitals located in Buffalo, New York City Center. Hospital A monitors for patient catheter infections by employing the nurses to use the best judgment by means of daily assessment protocol. Here, nurses not only provide daily care for catheters, but they also monitor for signs of infection. Signs that these nurses might include assessment of urine and color, odor, and indication of sedimentation, as well as monitoring the patient for changes in pain, such as pelvic or lower back pain that previously did not exist. The standard can be especially difficult for the patient who is not alert and oriented, as they are unable to verbalize the change in the pain, which is often viewed as the most prominent indication of a urinary catheter infection. Additionally, nurses at this hospital need a mid-level provider order to remove the catheter. Because of this, the order is often overlooked or administered later than need be. Hospital B uses many of the same protocols as Hospital A, such as a daily nurse assessment. The major difference between these two hospitals is that Hospital B uses a nurse-driven catheter removal protocol. In this protocol, the nurse is the indicator for when the catheter should be removed, and is able to do so without a mid-level provider order or consent. In addition, in order for a Foley catheter to remain in long-term, the physician must write a maintain Foley catheter order, which alerts the nursing staff that there is a specific reason why the catheter must remain in place. Because of the opposite driving forces between these two orders, Hospital B sees a quicker removal of catheters that are no longer indicated for the patient and reduces overall catheter infection rates. As a result of these various facts, risks, and indications, we are proposing the following question. Amongst hospitalized patients requiring a urinary catheter, how does early removal compared to extended catheter placement affect the rate of nosocomial infections over the course of an inpatient hospital admission? Here we seek to identify by means of observation and research of previous evidence-based practices the best method for our hospital to prevent catheter infections within the intensive care unit setting. In order to fulfill this study, we will need to provide an adequate amount of resources for the staff to implement the changes proposed. We will need an adequate RN staff who is well educated in catheter removal and indications for catheter-related infections. We will also need an educational staff that is available to support RNs should any questions arise in regards to new implementations or the catheter protocols. Since there will be a change in protocol, the completion of this will be monitored electronically. Therefore, we will need an IT staff to implement that change in the electronic record. Our proposed study will include 50 patients from our intensive care unit. These patients will be surgical patients who have had a catheter placed before surgery. The patients must be adults, aged 18 or older, and will have had the catheter longer than 48 hours. We will be excluding certain patients, including those with chronic long-term catheter use or those who use a straight catheterization prior to admission. Patients with existing UTIs or symptoms prior to admission will also be excluded from the study. In order to assess whether or not the new practice has been effective in our setting, we will need to measure the outcomes of infection rates amongst patients. We intend to monitor rates of infection and keep track of them electronically. From there, we will compare these results to previous infection rates prior to the implementation.
To implement this research design, we will be sure that all the participating staff on the unit are informed. They should also have proper training to care for patients with catheters and be knowledgeable of associated symptoms with the presence of CAUTI in a patient. We will then get consent from the qualifying patients whose data we will be gathering. Once we have our 50 participants, we monitor the data until their catheters are removed. We will evaluate the outcomes based on how long patients were using catheters and if there were occurrence of CAUTI or not. We will evaluate the process by using surveys for both patients and the staff helping to implement the design. We would adapt a change in policy based on decreased CAUTI rates in relation to shortened length of catheter use, patient satisfaction with lower infection rates, and staff satisfaction with proper patient care. For communicating a change in policy relating to decreased length of catheter use and the decreased incidence of CAUTI, we can use the hospital monthly newsletter, send out a mass email in the employee email system, mail out flyers via the United States Postal Service for those that don't frequent their email, and hold staff meetings. We can integrate change based on the results of this pilot design by using training workshops for current employees so their knowledge is up to par with evidence-based practice. For future employees, we can integrate additional training information in their orientation phase of hiring. We will continue to monitor the results of this evidence-based practice study based on rates of CAUTI and the length of catheter use. We can send out short surveys to both patients and nursing staff, reflecting on their personal experience of the relationship between CAUTI and catheter use. We can continue to monitor staff knowledge by using an annual online quiz, which will also help to keep the issue of CAUTI in the forethought of hospital staff and healthcare providers' minds. Finally, dissemination, or widespread circulation, of the results is important in integrating evidence-based practice. We could accomplish this by first submitting our results to the hospital newsletter, posting on hospital bulletin boards, and in hospital flyers and lobbies. We could reach out even further by contacting the local newspaper and nursing journals, both online and the ones in print.